This is one of the cases as IPCRG we developed on multimorbidity management in COPD, and it's supported by an unrestricted educational grant from Boehringer Ingelheim. This case study is about COPD and a patient with palpitations. This case study was developed by myself, Janwillem Kocks, general practitioner in Groningen, the Netherlands, and professor of inhalation medicine, and current president of the IPCRG, together with Kristian Hoines. Kristian, can you introduce yourself?
Yes, my name is Kristian Hoines. I'm a GP from Norway. I'm the current chair of the Norwegian branch of the IPCRG.
And together with Rudi Peche, he's a pulmonologist from Belgium. These slides are free to use for non-commercial presentations to your colleagues or patients. And first we start with a general introduction on multimorbidity management in COPD, and then we'll have a case study. It is provided under the Creative Commons license, which means you can use this for non-commercial use without a license grant. And if you are using these slides, please retain source information IPCD 2020 multimorbidity. What you will learn from this case study is actually why we focus on multimorbidity. Then what multimorbidity means for people with chronic respiratory disease, how we could improve the management, and how you could be part of that change. Patients with COPD typically present with multiple comorbidities, which may require long-term management alongside with their COPD. An additional challenge is that concomitant conditions can be overlooked because there are signs and symptoms that overlap with those associated with COPD. Up to 80% of patients with COPD have at least one comorbid condition, which is of clinical relevance. And half of COPD patients have 3 or more comorbid diseases. And comorbid conditions are more frequent in women than in men, and the prevalence increases with worsening of COPD severity. Comorbidities often appear in clusters, which suggest common risk factors, shared underlying pathobiological mechanisms, and side effects of COPD treatment. Some common comorbidities in COPD include cardiovascular disease, muscular weakness, diabetes, obstructive sleep apnea, and so on. Management of individual patients with COPD and multimorbidities is often complex and requires simultaneous application of several disease-specific guidelines. However, these guidelines do not align with regard to treatment recommendations in the face of multimorbidity. This slide set and this case study will assist you in the way of thinking around this problem. For patients with COPD, multimorbidity is associated with a high level of polypharmacy and increased risk of adverse drug reactions and interactions, an increased risk of hospitalization, and an increased risk of premature death. According to Goal 2020, in general, multimorbidity should not delay the treatment of COPD, and comorbidities should be managed according to usual standards. Attention should be directed to ensure treatment simplicity and to minimize polypharmacy. To improve the management of multimorbid COPD patients in primary care, we suggest together with GOLD, to optimize the treatment regimen according to GOLD classification and assess and treat comorbidities. For patients with multimorbidities, undertake a review of COPD treatment with a focus on the interface between symptoms of comorbid diseases and side effects of medication. In addition, think carefully about the indication of inhaled corticosteroid use before prescribing. Use in line with the guideline recommendation and note the latest IPCRG advice on appropriate use of ICS and guidance on ICS withdrawal. There are essential points of action. This long list you see here on the slide, we can take a pause to review this for yourself. One of the highlights is, of course, the inhalation technique and adherence to medication, and also to evaluate the indication before initiating ICS treatment. And we'll go into more detail in this entire series, but on regards to ICS treatment, consider that for asthma, ICS must be continued. For other diseases, really balance the need for the ICS. So the aim of this case study is to teach you how to identify and manage the multimorbidity in people with COPD. And with this, I hand over to Kristian to present his patient.
This patient is a quite common patient that is going to try to highlight some issues that might arise with a COPD patient with comorbidities. So this is a 60 years old male who's married. He's well educated. He's gone to business school, and he is also working as an accountant in a small business. He's a former smoker. He smoked from the ages of 16 to ages of 45, and he is inactive. I would suggest that you, after each slide, please take a few minutes to consider if this is a patient that is known to you and if you have any special thoughts about them. This patient was mostly healthy, but at the age of 50, he had 3 lung infections. One was treated by his family doctor, and twice he was attending an emergency room. As a child, he had bronchitis, but not after his 12th birthday, so he thought this was nothing to consider when he was grown up. And he can tell that no particular diseases runs in the family. Considering his respiratory history, he had an appointment to the doctor's office 1 year ago. When we review that, we find that there were no normal findings on his lungs. He had a normal heartbeat. He had a slightly elevated blood pressure of 155 over 85, and he weighed in at 79 kilos. There were performed a spirometry at the doctor's office, which concluded with a moderate obstructions. The pre-test FEV1 FVC ratio was 1.65, and the FEV1 was 2.17 liters, which is 60% of the expected. The post-test was with an FVC ratio of 0.64 and an FEV1 of 2.28 liters, which is 65% of expected, and a change of 8%, which concludes with a negative reversibility test and an obstructive spirometry. And then we performed a CCQ score with a total score of 1.8. And you, Janwillem, you know a lot about the CCQ score. Could you please explain to us something about this score?
Yes, sure, Kristian. So the CCQ score, the CCQ is a 10-item questionnaire, and I'll show it on the next slide as well. But it's a score between 0 and 6. And if you go back to the previous slide, I'll show you. So there are the scores are has a couple of domains: the symptoms, the mental state, and the functional status. And if you look at at these scores from the patient, you actually see the total score is reasonably high, which is mainly caused by the symptoms and functional status. There's no problem in the mental state here, so the suggestion for treatment would really to be focusing on the symptoms and functional status. So this is the CCQ. It's one of the questionnaires recommended by GOLD next to the MRC and the CAT score. It's 10 items, takes less than 2 minutes to complete, and in comparison with the other questionnaires, it has several domains. So it has symptoms, mental status, and functional status, which could actually guide you in which direction do you want your treatment to be on. So on symptoms, it could be mainly with pharmacotherapy, but on functional status, supported by pharmacotherapy would actually be physical therapy, for example. The minimal clinically important difference is 0.4 points, which means if a patient score increases or gets better or gets worse by 0.4 points on the CCQ, this actually represents a clinically important change. It's available over 80 countries and it can be downloaded.
Treatment, this patient was started on ICS LABA fixed combination twice daily, and he also got a SABA as needed. He was highly motivated and started exercising with a focus on completing a half marathon, and he lost 10 kilos of weight. But then, as a lot of patients do, he failed to meet for a planned follow-up, even though this was actually organized. Then to some clinical considerations. 1 year has passed and he contacts the office with increased dyspnea. He has had increasing problems during training for the last 3 to 4 months. He feels like he has no effect of his training. He feels fatigued. He has increased the use of SABA to 4 to 6 times daily, and he explains that this has no effect at all. He almost feels worse at some times when he does the SABA. He's got heavy heartbeats, but he's considered himself that this is due to the increase of use of SABA, since he's been informed that this might be a side effect. When we look into the patient's file, it reveals that he has 2 ER contacts with a course of antibiotics for bronchitis over the last 12 months. So let's consider some questions. I would suggest that you do take time to discuss this among you, or think through it by yourself if you are alone. Do we need any more examinations? What are the reasons for the increasing dyspnea? And is the medication correct? Is he using the inhaler correctly? And what is his adherence? So what would be really important is to confirm if the patient manages the condition appropriately. The patient could be overusing SABA, and it is, from the information you've currently been presented, quite unclear if he still uses his controller medication. So then we did some tests. We did a new spirometry, which had improved since the last contact. It now had an FEV1 of 74% of predicted, which used to be 65%. And we did an ECG, and that showed atrial fibrillation with a heart rate of 80 beats per minute. His blood pressure was 145/70. And we did some laboratory tests with which showed an hemoglobin of 8.9 and a blood eosinophilic count of 0.3. All of these points are of importance, but 0.6 should be particularly considered. One should closely monitor for cardiac rhythm disorders, including atrial fibrillations, when initiating patients on LABA. So that is really important to remember. So are there any indicators of multimorbidity in this case? Well, the patient is referred to the hospital for treatment of the atrial fibrillation, and it spontaneously returns to regular rhythm. He had a low Shad-Svask score and no need for antithrombotic.
So here we present a new medication plan. Given the improvement of lung function using the ICS-LABA therapy and the blood eosinophils of 0.3 and the bronchitis attacks he had, ICS is likely to show benefit in his case. But given the atrial fibrillation, the adrenergic effects of both SABA and LABA should be looked at with caution. But given the need for bronchodilation, LAMA, a long-acting muscarine antagonist, would be the preferred choice. if you need to choose between LABA and LAMA. But the combination of ICS and LAMA does not exist. And we know that mixing of devices may lead to worse inhalation technique because of the differences in types of inhalation that's required. A pragmatic choice would be to make sure that the ICS-LABA is used with a low dose of ICS, and a LAMA could be added as a bronchodilator, and as a rescue medication, the SABA should be changed to a SAMA. And if he still continues to have palpitation or atrial fibrillation, use of two inhalers, separate ICS and a LAMA separate in a similar device would be advised. And of course, when changing medication and changing inhalation device, proper inhalation technique should be reviewed, considered, and changed and taught if needed. Of course, there are other recommendations. So please consider the vaccinations, influenza and other vaccinations depending on your local guidelines. And again, check the inhalation technique, not only when you prescribe, but every time you see this patient, because medication that's not correctly inhaled will not have proper effects. And with that, Rudi, Kristian, and myself would like to thank you for looking at this case, reviewing, and we hope that you had the chance to consider the steps we took, and this would help you in similar cases to do clinical reasoning to actually manage a patient with multimorbidity under which COPD, to adjust your treatment to fit that individual patient. We'd like to thank the IPCRG for making it possible that we do this, and Boehringer Ingelheim for their unrestricted grant for making this possible.